Evening, dear my friends and professional colleagues. This is Dr.Sepuri, Senior Endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So today we are going to talk about the circle of protection that's given by the dapagliflozin. And today's topic will be the combination of SGLT2 inhibitors and the DPP4 inhibitors in the management of type 2 diabetes mellitus. So, I would request all the participants to type your queries or questions in the chat box so that we'll take it up at the end. So, with that, I'll just move on to the next slide. Yeah, this is the disclaimer and the table of content that we are going to talk about is the diabetes epidemiology, the combination therapy in the management of type 2 diabetes mellitus, the combination of SGLT2 inhibitors and the DPP4 inhibitors, and the dapagliflozin and the sitagliptin combination, the guidance for initiation of SGLT2 inhibitors and the DPP4 inhibitors combination in the management of type 2 diabetes, and the last part will be the take home message. And this slide you can see the diabetes mellitus in India. Let's talk about the epidemiology first. So as per the 2021, the 10th Atlas of the International Diabetes Federation, the Diabetes Atlas, the 10th edition, 2021, the China is on the top. The diabetes capital of the world is China with 140.9 million patients of diabetes, and the India is the second country with 74.2 millions. And until 2012, the WHO has accredited India the diabetes capital of the world actually, and later on China surpassed India, and the exposed the proportions for 2045 will be like China will be on the top with 174.4 million. You can see the difference from 141 million. It's somewhere around some 174 million, but when you take India, it's from 74, it's almost getting a little bit doubled actually. It's around some 125 millions. The projection for 2045 according to the International Diabetes Federation, the Atlas, the 10th Atlas, that is 2021. So the real world evidence of glycemic control among the patients with type 2 diabetes mellitus in India, the TIDE study. On the left hand side you can see the bar diagram which shows the y-axis that shows the percentage, and the x-axis shows the male and female. The male are in the dark black diagram, and the female are in the white bar diagram. And the first one is less than the A1C of less than 7%, and the second bar is 7 to 8%, and the third bar is 8 to 10%, and the fourth bar is more than 10%. So you can clearly see that the A1C is above 7 in majority of the second, third, and the fourth bar diagram. And only the first bar diagram shows some percentage like 24% of people maintaining a glycosylated hemoglobin of less than 7%. And the inference of this particular the bar diagram is the retrospective analysis of the 55,639 patients with type 2 diabetes, and 76.6% of the patients had uncontrolled HbA1c of around or more than 7%, that is less than a quarter or to the target, that is around or less than 7%. And so you can clearly see this the diagram, the slide, the cartoon shows diabetes as a cardiovascular risk factor, and on the left hand side you can see the coronary artery disease, and the prevalence is 14 to 21%, and most frequently reported from the cardiovascular disease, and it is the most lethal one actually. So the next comes the heart failure. The prevalence is 19% to 26% actually. The second most common, the initial manifestation of cardiovascular disease in type 2 diabetes, and the risk of heart failure is up to twofold in men and fivefold in women. And coming to the peripheral artery disease or peripheral vascular disease, PVD or PAD, the prevalence is 16 to 29%. These are all the macrovascular complications of diabetes, and the most common initial manifestation of the cardiovascular disease in T2DM, and the prevalence is 1.8 fold higher in women compared to men. And the last one is stroke. The prevalence is 8 to 12%. And second most frequent common cause of the death in patients suffering from the type 2 diabetes mellitus after the coronary artery disease, and the prevalence is similar in men and women. And coming to the right hand side, we just see the microvascular complications of the diabetes, namely the retinopathy. The prevalence is 34%, the most common microvascular complication of retinopathy. But according to the Harvard Medical School and the Joslin Diabetes Center, the prevalence of the retinopathy in type 2 diabetes is 96% actually. This is the latest update actually. And so most common microvascular complication of the diabetes, and they are responsible for 2.6% of all causes of blindness around the globe, and the prevalence rates are higher in type 1 diabetes compared to the type 2 diabetes, that is 77.3% versus 25.2%. And neuropathy, any degree of neuropathy, it is sensory, motor, or the autonomic neuropathy, again autonomic neuropathy, the cardiac autonomic neuropathy, the gastrointestinal autonomic neuropathy of the external genitalia, that is in the form of the erectile dysfunction or the premature ejaculation, or sometimes the combination of both ED and PE. And the prevalence is 31 to 73% of the people with type 2 diabetes, and no difference in prevalence between men and women. And the cardiac autonomic neuropathy is the dreadful and dreadful number one killer, that is in the form of SCD, sudden cardiac death actually. And nephropathy, so the exact term according to the American Diabetes Association from 2016 is the diabetic kidney disease. So rest of the world they still call it nephropathy. As far as ADA is concerned, we just call it DKD, diabetes kidney disease, and the prevalence is 29 to 61%. And this is the leading cause of end-stage renal disease, ESRD or the ESKD, in the adult population all over the world. And female sex is a risk factor for nephropathy in type 2 diabetes mellitus. So this is all taken from the European Journal of Preventive Cardiology 2019. And the importance of multifaceted management of cardiovascular risk factors, you can very clearly see in the center you can find this cardiovascular risk, and you have multiple factors which lead to this particular cardiovascular risk, starting from the top, like we take the abnormal lipid metabolism, so that can be controlled by the meticulous control of the dyslipidemia, they target the LDLC all the time, so control cholesterol. And age, race, sex and family history, and these four, the others are the modifiable risk factors, whereas the age, race, sex and the family history, they come under the unmodifiable risk factors. So at least we try to modify the modifiable risk factors, because we can never modify the unmodifiable risk factors. So coming to the hypertension, so which is a very important cause for the cardiovascular disease or the death. And so simple thing is manage the high blood sugar, the high blood pressure, and the smoking. You can stop smoking. And coming to this, the insulin resistance, maybe it's the originated from either the genetics or the age, and the insulin resistance and the pre-diabetes, diabetes and the metabolic syndrome. And on top of it, you find physical inactivity, overweight and obesity. So to counter this, you can eat better and get active. And all these problems, the insulin resistance, pre-diabetes, diabetes, and metabolic syndrome can be managed by reducing the blood sugars very meticulously. And as far as the overweight and obesity is concerned, you can lose the weight all the time. So with all these measures, you can definitely decrease the cardiovascular risk. So all the time remember the lifestyle modification as well as the therapeutic lifestyle changes. That is the diet, exercise, the reduction in the weight, cessation of smoking, and cessation of alcohol. So the effect of multifactorial intervention in the type 2 diabetes, this is according to the STENO2 study. So the left hand side you can see the conventional therapy in the red red color, and the intensive therapy in the blue color actually. So the x-axis is the years of follow-up until the 15 years it was followed up, and you can see the curves getting started from the beginning. It is the conventional therapy is going up and the intensive therapy is coming down. So the p value is less than 0.001, that means which is statistically very significant. And intensive control of several cardiovascular risk factors including the HbA1c, the blood pressure, and the lipid profile in patients with type 2 diabetes and albuminuria reduced the composite events by 53% during 7.8 years of follow-up. And the combination therapy versus the stepwise approach in type 2 diabetes mellitus. See, let us see the first the stepwise therapy on the left hand side, the potential advantages, and on the right hand side you can see the combination therapy, and it has got its own potential advantages. The stepwise therapy, the potential advantages are easier to assess the efficacy or the side effects of the new drug added, risk to benefit ratio, and easier in the individualization of the therapy and the cost. And the combination therapy, the advantages are use of drug combination aimed at targeting multiple pathogenic mechanisms simultaneously, preferably by complementary mechanisms of action. Like the best example is the metformin and the combination of the SGLT2 inhibitor and the DPP4 inhibitor, which complement each other to the counter the ominous octet of the pathophysiology of the type 2 diabetes as postulated by my own mentor Ralph Anthony DiFranco. So earlier and the greater achievement of glycemic goals because of the combination therapy when compared to the stepwise therapy, the potential delay in the disease progression and the preservation of beta cell function, that is the combination therapy is going to
recording in progress.
yeah the, so the combination therapy is going to prevent the beta cell exhaustion as it is, and is going to prevent the beta cell bankruptcy and the reduction in the clinical inertia. And now the funda is treat early and treat right, that is hit early and hit hard. This is the funda as far as the management of diabetes goes on. Screen share? Okay.
Please continue, sir.
Yeah, yes. Sorry for the technical glitch, okay. This slide shows the regimen simplification and the medication adherence, the fixed dose versus the loose dose combination therapy for type 2 diabetes mellitus. According to this Kaplan-Meier curves displaying the proportion of the individuals without discontinuation of the treatment in the fixed dose combination and the loose dose combination, we call it as FDC and LDC cohort, okay. So you see this FDC cohort in the blue line, whereas the LDC in the brick red dotted line. So you can see the again the curves getting separated from the beginning. So the FDC can lead to a significant improvement in the adherence of the pharmacological therapy of the type 2 diabetes compared to a loose dose combination. So now this is a busy slide actually. The complementary mechanism of action of this particular SGLT2 inhibitors and the DPP4 inhibitors. On the left hand side you can see the multiple mechanisms of action by SGLT2, as well as on the right hand side the DPP4 inhibitors respectively. So the SGLT2 inhibitors, so by increasing the urinary glucose excretion, the activity of NHE3 and the glucotoxicity and the plasma volume, and the decreasing the glomerular hyperfiltration, and the sensitivity of the increasing the sensitivity of the beta cells, and reducing the insulin resistance, and reducing the sympathetic tone, and reducing the activity of NHE1, and increasing the hemoglobin and the hematocrit. So and the endogenous hepatic, the increasing the endogenous hepatic glucagons. Until these are the actions of this, and the DPP4 inhibitors, starting from the increasing the insulin secretion, the incretin effect, the GLP1, and increasing the GIP, as well as the increasing the endothelial function, and the decreasing the macrophage infiltration, and decreasing the calcium deposition, and the reducing the oxidative stress and the inflammation. And the counteraction is there is some cross reaction in this particular this one. The SGLT2 inhibitors increase the endogenous glucagons, whereas the DPP4 inhibitors they decrease the endogenous, that is hepatic glucagons. So this is called treat to target actually. So you can clearly see the SGLT2 inhibitors are the drugs which act through the kidney actually. So the SGLT2 receptors are present in the proximal convoluted tubules, and the SGLT1 receptor present in the proximal straight tubules. So we are basically now targeting the SGLT2 inhibition, and the DPP4 inhibition takes place in the gut along with the GIP. And they both put together, the DPP4 and the SGLT2, they have an action on the pancreas and at the level of heart also. So this is they call the synergistic effect. So at the level of kidney, by decreasing this the SBP and the estimated glomerular filtration, and reducing the albuminuria, reducing the body weight, and reducing the serum uric acid, the SGLT2 inhibitors they act by kidney by the above mentioned the mechanisms of action actually. So at the level of pancreas, the hyperglycemia is reduced, and the serum uric acid and the systolic blood pressure and the hypoglycemic risk is reduced. And as far as DPP4 inhibitors, if you take this weight, the weight neutrality is found, whereas the weight reduction is seen specifically with the SGLT2 inhibitors. And the cardiovascular, you take the DPP4 inhibitors, though they are not very favorable drugs in case of the cardiovascular events, that is like either the 3-point MACE or the hospitalization for the heart failure or the heart failure. So at least they are neutral to this three parts of the cardiovascular disease. So this is got a synergistic activity in between the DPP4 and the SGLT2 inhibitors. And the efficacy of modern diabetes treatments, that is DPP4 and SGLT2 and GLP1 receptor agonists in white and Asian patients with diabetes, a systematic review and meta-analysis and the randomized control trials. See, this slide simply says that, okay, so when you take this, the SGLT2 inhibition as well as the DPP4 inhibition, it is very effectively seen in the Asians actually when compared to the Caucasians. So the reductions fasting plasma glucose as well as the postprandial plasma glucose as well as the HbA1c is more seen with this Asians, especially the Indian population, the Southeast Asian population, that is our Indian subcontinent, when compared to the Caucasians, the whites, and also the same DPP4 inhibition also to some extent. There is enough evidence based medicine to say that there is more DPP4 inhibition in the Asian continent when compared to the the Caucasians. So that results in the greater reductions in the HbA1c in the Asians used when you used the combination of SGLT2 or this DPP4 inhibition when compared to the Caucasians. So the similar change is not seen with the GLP-1 receptor agonists. So ethnicity is not at all a difference as far as the GLP-1 receptor agonists are concerned. But whereas SGLT2 and the DPP4 inhibitors are concerned, there are several randomized controlled trials, RCTs, to say that it is very efficacious in Asian population when compared to the Caucasians. So this is a meta-analysis of the 64 randomized controlled trials. The glucose lowering efficacy of SGLT2 inhibitors and to a lesser extent DPP4 inhibitors was greater in studies of predominantly Asian ethnicity compared with studies of predominantly white ethnicity, and no difference is seen by ethnicity for GLP-1 receptor agonists. And now we see the SGLT2 inhibitors in combination with other the anti-diabetic drugs. You can see a lot of drugs are there: metformin, SGLT2 plus GLP-1 receptor agonists plus DPP4 inhibitors plus thiazolidinediones plus sulfonylureas plus insulin. And this is a busy slide actually, and you can see the multiple parameters. They have taken the insulin secretion, the glucagon secretion, and the hepatic glucose output, and the insulin sensitivity, the body weight, and the food intake, and the systolic blood pressure, HDL bar LDL ratio, the diuresis, the asthmatic and the natriuretic, and the cardiovascular events, and the heart failure events, and the new or worsening of the nephropathy. You can very clearly see that the combination of the SGLT2 inhibitors in combination with GLP-1 receptor or the DPP4 inhibitors are very complementary in they are very synergistic in the combination rather than the single loose drug combination actually. So the combination of SGLT2 inhibitors and GLP-1 receptors or the DPP4 inhibitors appears to be the promising therapy. So according to the first the recommendation rolled out from the European Society of Cardiology way back in 2019, saying that the ESC said whenever the patient comes, the de novo type 2 diabetes mellitus, so whether at risk of developing atherosclerotic cardiovascular disease or the patient has got the established cardiovascular disease, irrespective of metformin, whether you start metformin or not, you can straight away go for either the GLP-1 receptor agonist, where the atherogenic 3-point MACE predominates, and the heart failure predominates. You can straight away go for this SGLT2 inhibitors, and if both are combined, you have got a very synergistic effect with these. So this is the recommendation that rolled out way back in 2019 by European Society of the Cardiology actually, and later on the EASD joined hands with this in the recommendations, and now the American Diabetes Association and the American College of Endocrinology and even the American Association of the Clinical Endocrinology also they said the same thing. But the ADA and the American body said the metformin should be the first drug of choice for in the treatment of type 2 diabetes mellitus, unless otherwise it is contraindicated. Added to that, as a second drug, you can take up this particular DPP4 inhibitors or SGLT2 inhibitors or the GLP1 receptors, and if required, insulin. So as far as glycemic control is concerned, the slide shows the SGLT2 inhibitors and DPP4 inhibitors. As far as the glycemic control is concerned, you can clearly see the bar diagram. The first diagram shows the empagliflozin and the linagliptin and the combination of both. And the second one shows the ertugliflozin. This is one the SGLT2 inhibitor which is available in the United States of America actually. So it has got a wonderful cardiovascular outcome trial, what is CV, but somehow it was a little bit, what is CV was a disappointing, disastrous results when compared to the 3-point MACE, where it is supposed to show some promising results like the dapagliflozin and the empagliflozin and the canagliflozin. But it showed promising results with regards to the heart failure benefits, but not with the 3-point MACE, and the sitagliptin and the combination of ertugliflozin and the sitagliptin. And the last is the dapagliflozin, the saxagliptin, and the combination of dapagliflozin and saxagliptin. And when you see the HbA1c as a parameter, the empagliflozin was able to reduce the A1c by 0.7%, and the linagliptin same 0.7%, and when put together the EMPA and the LINA, the reduction of HbA1c was 1.1 actually. So when you come to this ertugliflozin, it was 1% reduction, and the sitagliptin was 1.1%. In combination, that is ertugliflozin and sitagliptin showed a reduction up to 1.5% of A1c. And coming to dapagliflozin, it showed 1.5%, saxagliptin 0.9%, and the combination of saxagliptin and dapagliflozin that showed 1.2% reduction. So it shows, see, alone dapagliflozin was able to reduce to a tune of 1.5. So when combined with saxagliptin, it was not synergistic actually. So it showed less promising results in reducing the A1c. That is, when compared to 1.5, it is only 1.2% reduction. So significant reduction of HbA1c with the SGLT2 inhibitors, the combination therapy compared to the monotherapy with the gliptins. So this is with regards to the effect on BP and the weight. The same groups, the three groups, empagliflozin, linagliptin in combination, A2 and the sita and the combination, DAPA and saxa and the combination. The reduction in the body weight is the empagliflozin alone was able to reduce by 2.5 kilograms, whereas linagliptin was 0.7 kilograms, and the combination was able to reduce to a tune of 2.6 kilograms. So ertugliflozin was 2.7 and the sitagliptin was 0.7, and put together ertugliflozin and sitagliptin was less than around some 2.5 kilograms, and the dapagliflozin 2.4 and the saxagliptin 0. That is weight neutral. I told you in the beginning itself, the DPP4 inhibitors are weight neutral in their action. They don't reduce the weight actually. So at least they don't increase the weight. That is the beneficial point. So weight neutrality is also like cardiovascular neutrality and weight neutrality are the two plus points with this DPP4 inhibitors. So when you take this the weight, they put together both this dapagliflozin and saxagliptin, it was only 2.1 kilos. And when it comes to systolic blood pressure, that is the alone empagliflozin was able to reduce the SBP by 3.5 millimeters of mercury, and there is no action of linagliptin actually. So in fact a little bit the 0.3 millimeters of mercury was increased, and put together the combination was able to reduce only 2.8, and the same ertugliflozin respectively 3.9 and 0.7, and put together 3.4, and when you take the dapagliflozin, the reduction was 3.5, and the saxagliptin same, the no weight reduction, and when put together the dapagliflozin and saxagliptin, it was 1.9 kilograms respectively. So the synergistic effect we definitely find with some, we don't find with some. And significant reduction of systolic blood pressure and body weight with the SGLT2 inhibitor combination therapy compared with the monotherapy with gliptins. Actually, the initiation of SGLT2 inhibitors in a patient who is already suffering from the hypertension, or say the resistant hypertension, it is very much effective because there is ample evidence-based medicine. But there are multiple RCTs which say that the SGLT2 inhibitors, especially, they control the daytime BP, the morning BP, the nighttime BP, the 24-hour BP. This is especially the considerably the systolic blood pressure is very much reduced when compared to the meager reductions in the diastolic blood pressure, and it reduces the nocturnal hypertension, which is the number one killer for this particular cardiovascular disease, that is either the acute myocardial infarction or the strokes. So addition of the SGLT2 inhibitors to the standard treatment of the hypertension, whether it is nocturnal hypertension or the resistant hypertension or the simple essential hypertension, is going to benefit this particular the standard protocol of the treatment along with the addition of SGLT2 inhibitors. And this slide shows that this is a very busy slide that shows the safety of this particular combination, the SGLT2 inhibitor and the DPP4 inhibitors. You can clearly see the studies, the Levin study and the DiFranco et al. And the Rosenstock, and then the Matthew and the Mathai and the Jabbar. All these studies, they said the hypoglycemia is very negligible, and there is one side effect you just have to remember with the SGLT2 inhibitors. It is all the time the genitourinary infections, either in the form of urinary tract infections or in the form of the mycotic infections, that is the candidiasis of the genitalia, either the vulvovaginitis in females or the balanitis or posthitis or balanoposthitis in males. So you just have to keep a watch on that particular complication, the side effect, and you have to be very vigilant while starting this particular. See, the companies all the time, the pharma companies always, they say when to use a drug, but they never say when not to use a drug. See, I am highlighting this particular point. See, when not to use this SGLT2 inhibitors. So that is, first is the recurrent or the re-recurrent the genitourinary infections is one of the definite contraindications of this particular SGLT2 inhibitors. We cannot initiate in them. And second thing is the dehydration is the worst the side effect of this SGLT2 inhibitors. So whenever you prescribe SGLT2 inhibitors, just put in some 2-3 inputs to the patients always. It's like maintain a genitourinary hygiene, and second thing is adequately get hydrated actually, because dehydration is going to kill the patient actually. So, and the third thing is the euglycemic decay, and this is very important. Euglycemic decay is commonly seen with this all the class of drugs which are available right now in our country, the dapagliflozin and the empagliflozin and the canagliflozin. It is nothing but it's a type of DKA. That is the thing is, the DKA, the blood sugars are very high. It's always more than 250 milligrams per deciliter, and you always find a metabolic acidosis that is less than 0.73, and always you find the low soda bicarb, that is less than 18 milliliter equivalents per liter. This is the common pattern of the DKA. The EDKA, that is euglycemic DKA, differs only in one aspect, that is the blood sugars are either near normal or near normal or little bit elevated. So that is the definition of euglycemic DKA is all the time the less than the blood sugars of less than around or less than 250 milligrams per deciliter, and the metabolic acidosis, that is the pH less than 7.3, and an anion gap, and this particular the lows, so soda bicarb less than 18 milliequivalents per liter, and the blood and urinary ketones must be checked, and they must be positive, both must be positive in euglycemic decay. So these are all the conditions where you cannot go for, or where you have to be very, very cautious. If you miss a diagnosis of euglycemic decay, the patient lands up in a very serious condition. If you miss that, you miss the patient. And it is not confined. The euglycemic decay is not only seen with this the SGLT2 group of drugs. It is seen in pregnancy. It is seen in prolonged fastings also, along with the drugs, because this particular term euglycemic decay was coined way back in 1976 itself, when there was no SGLT2 inhibitor, no other diabetic medication was present except the insulin and the sulfonylureas and the metformin was present. Beyond that, nothing was present. So euglycemic decay is not only particular characteristic of this particular the SGLT2 inhibitor, and it can be seen during pregnancy and the prolonged fasting. But whenever you get a case and the drug history says that the patient is on SGLT2 inhibitor, you have to stop it immediately and treat the patient very meticulously with adequate hydration, that is with normal saline, and with if it is not available, you can go for even ringer lactate also. And the adequate hydration, parenteral nutrition is very, very important. And next is the insulin drip plays a very vital role. And when it goes below the 200, you have to start simultaneously the 5% dextrose drip and all. If at all there is any electrolyte imbalance, you need to monitor every 2 hourly, and you have to treat the metabolic acidosis and all, everything very meticulously. So next slide. So the overall safety profile of combination is similar to those of the individual components. So now this is the DPP4 inhibitors, they moderate the risk of genitourinary tract infections associated with SGLT2 inhibitors. Yes, the combination actually, when we see the patient is on only SGLT2 inhibitors, the incidence rate is little bit high. But when SGLT2 inhibitor is used along with the DPP4 inhibitor, there is the little reduction in the incidence of this particular genitourinary infections, maybe because of the two reasons actually. So the first reason is because of the DPP4 inhibition in the bacteria, as well as this particular the candidial infections. And second thing is the DPP4 inhibitors reduce the pH of this particular genitalia, so that it is not favorable for this either the bacteria or the candidial infections to set in. So the relative risk, you can clearly see this the combination that favors the SGLT2 and the DPP4 inhibitors is always beneficial in reducing the genitourinary tract infections. See the meta-analysis of 5 OSCTs directly comparing the frequency of genitourinary infections in patients receiving the combination of DPP4 inhibitors and SGLT2 inhibitors, the combination therapy versus those receiving only SGLT2. And the lower rates of GTA were reported with the FDCs as compared to SGLT2 monotherapy. So the global and Indian approval status of SGLT2 inhibitors plus combination of DPP4 inhibitors, that is FDC. So the FDC, the US FDA approval and the DCGI approval, and the commercially availability in India. So coming to the empagliflozin and linagliptin, that was the first molecule to be approved by US FDA way back in 2015 and DCGI in 2017, and it is available in our country from 2018. Whereas the combination of dapagliflozin and saxagliptin got USD approval in 2017 and DCGI in 2019 and commercially available in India from 2020. Whereas etugliflozin is not available actually. Etugliflozin and sitagliptin, with these two molecules, they belong to the Merck, E-Merck. Empagliflozin and linagliptin, they belong to Boehringer Ingelheim. And the dapagliflozin and the saxagliptin, they belong to the AstraZeneca. And this etugliflozin is the sitagliptin. The US FDA has given approval in 2017, but it is not available in our country. And the Indian gliflozin, remogliflozin, and vildagliptin. Obviously, the US FDA never gives approval to these the combinations. The dapagliflozin plus vildagliptin, the remogliflozin plus vildagliptin, and the dapagliflozin with sitagliptin also. Definitely, they don't get the US FDA approvals. And we have got DCGA approvals for all the three, the bottom line drugs, the remogliflozin plus vilda and the dapa plus vilda, the dapa plus sita from 2020, 2022 and 2022 respectively. And it is commercially available in India from 2020 and 2022 and 2022 respectively. So the new FDC in the management of type 2 diabetes, the dapagliflozin and the sitagliptin. And on the left hand side, you can see the advantage of dapagliflozin, proven cardiovascular benefit as the backed up by the lot of evidence-based medicine, the randomized controlled trials, and the CVOTs, that is cardiovascular outcome trials, declared TME58, the DAPA-HF and the DAPA-CKD, and off late the deliver trial, which was the results of deliver trial, which were rolled out in the European Society of Congress, which was held in the month of August at Barcelona, Spain. So deliver trial is the latest one that was done with dapagliflozin to see the benefits in the HPF patients, that is heart failure with preserved ejection fraction and the heart failure with mildly reduced ejection fraction. So the extended indication is one, heart failure with reduced ejection fraction. The second is CKD, and the greatest advantage of dapagliflozin is the US FDA has said the empagliflozin and dapagliflozin can be used in patients in the absence of even the diabetes, as far as the heart failure and the CKD are concerned. And the beneficial pleiotropic effects, actually this is a wonderful pleiotropic drug. Not only the dapagliflozin, the empagliflozin and the dapagliflozin, these two are the beautiful pleiotropic drugs. We call metformin in our armamentarium, we call the first drug I call is metformin is a wonderful pleiotropic drug, and second thing is statin, and third is the SGLT2 inhibitors, especially the empagliflozin and the dapagliflozin. So apart from the glucose, it emerged as a glucose reducing agent. Later on, it reduced the significantly the systolic blood pressure, and it reduced the weight. And afterwards, we saw the cardiovascular benefits in the form of the reductions in the 3-point MACE, the 4-point MACE, and the 5-point MACE. And regarding the heart failure and hospitalization for the heart failure, and later on we saw the beneficial effects on the chronic kidney disease in improving the estimated glomerular filtration, and later on we saw the beneficial effects on the liver also in the form of the reducing NAFLD and the NASH, non-alcoholic fatty liver disease, and the non-alcoholic steatohepatitis. So it reduces the uric acid levels also, hyperuricemia, which is very common in diabetes. See, diabetes is always associated with the hyperuricemia and hypothyroidism. Vice versa, like hypothyroidism is also associated with hyperuricemia and this particular type 2 diabetes. And likewise, hyperuricemia, the gout, is always associated with type 2 diabetes and hypothyroidism. And the clinical benefits for other conditions like NASH, prediabetes, heart failure with preserved ejection fraction, not only preserved, with the reduced and the mildly preserved also, and obesity and PCOS, it has got a wonderful role. And when you come to sitagliptin, the convenient once daily regime and the low potency, most of the like only barring some like only this particular vildagliptin. Apart from that, all the gliptins, all the DPP4 inhibitors are once daily. You take sitagliptin, you take linagliptin, you take the saxagliptin, whatever you take, it is once daily only. But only thing is the vildagliptin has to be taken 50 milligram twice a day. And off late, the 100 mg SR has come into vogue in Indian scenario. And even the latest the RCTs say that that is equivalent to giving the vildagliptin 50 mg twice. Is as good as the giving vildagliptin 100 mg once a day. And convenient once daily regime and low potential for drug to drug interactions, safe and effective as monotherapy and in combination with other OADs, and low risk of hypoglycemia and weight gain, and it is CV neutral. And that's what I said, it is weight neutral and CV neutral and low risk of. And in this particular juncture I would like to highlight one single point. If the patient is suffering from heart failure, please never use saxagliptin in that particular patient, because saxagliptin may induce heart failure. And also try to be very cautious with this particular, because the Sevar Timi 50 the 3 has proven this particular which favors the heart failure actually. So it may induce. And the other drug is alogliptin is one where you have to keep an eye when you are using it along with the patient who is suffering from heart failure. Better you avoid these two drugs. First of all, you can never use saxagliptin, because saxagliptin is a contraindicated drug in heart failure. And alogliptin also you have to be very cautious in patients suffering from heart failure. And one more thing regarding this particular the vildagliptin, you have to be, see, it doesn't per se induces heart failure, but in the long run the constant use of this particular vildagliptin is associated with the increased lung, the left ventricular volumes actually, sorry, not lung actually, it is the increased left ventricular volumes, which may later on lead to heart failure. That was evidenced by VIVID study, that is VIVIDD, that is VIVID study, that is a cardiovascular outcome trial actually. And coming to the summary of cardiovascular outcome trials of dapagliflozin, they declared to me, said the type 2 diabetes who had were at risk of atherosclerotic cardiovascular disease. The patient population was 17,160, and the results, the 27% relative risk reduction of hospitalization due to heart failure, and the DAPA HF, that is the patient population was 4,744. The NYHA classification, the New York Heart Association, the class 2, 3, 4 heart failure and ejection fraction of less than or around 40, that is the heart failure with reduced ejection fraction, that is HREF. And it has shown the results were 26% relative risk reduction of composite and worsening of heart failure or cardiovascular death. And when you come to the DAPA CKD, it is probably the only one study that USFDA said you can stop it prematurely 6 months before the scheduled time actually. So this has got a wonderful results. So the USFDA was thrilled with the overwhelming response of dapagliflozin, the role of dapagliflozin in the preventing the progression of the chronic kidney disease in diabetes or in absence of diabetes. That is the glomerular filtration of 25 to 75 ml per minute per 1.73 meters square of body surface area, and urine albumin to creatinine ratio with albumin measured in milligrams and creatinine measured in grams of 200 to 5000. So that is that corresponds to 25 ml per minute to 75 ml of EGFR actually. So the result is 39% relative risk reduction in sustained decline in the estimated glomerular filtration rate of at least 50%, and end-stage kidney disease or death from renal or cardiovascular causes.
Recording in progress.
And one more thing, as far as the the DP4 inhibitors are concerned, the thing is you have to down titrate the dosage of all the DPP4 inhibitors in case of CKD, that is when the EGFR goes below 45 ml, you have to be very cautious. You should reduce, like sitagliptin, you are using 100, you have to come down to 50, and if it is still reducing, you have to come down to 25. Likewise, vildagliptin 50 mg 1 BD should come down to 50 mg OD. As saxagliptin 2.5 milligram, you should come down to 2.5. And the only one drug that doesn't require any sort of dose titration in any degree of the CKD, the any stage of CKD, 1, 2, 3A, 3B, 4, 5, even during the transplant, even during the dialysis, even during there is a subset called the new onset of type 2 diabetes after the kidney transplant. Along with insulin, you can use all these molecules, but linagliptin has got the special peculiar feature that it can be used in any degree of EGFR actually. So all others, they need down titration. You have to be very cautious with all this. And as far as the dapagliflozin is concerned, once it goes down, earlier the recommendations were if it goes below the EGFR goes below 45 ml per minute, you have to stop the empagliflozin or canagliflozin. And after the credence that was done with the canagliflozin, so ESFD said canagliflozin can be given up to around or more than 30 ml of EGFR, and later on the seeing the overwhelming response with DAPA CKD and the EMPA kidney, the cutoff points were reduced to around or above 30 ml per minute of EGFR for the dapagliflozin, the canagliflozin and the empagliflozin. So the main features of the 5 marketed DPP4 inhibitors, you can very clearly see the sitagliptin, the vildagliptin, saxagliptin, linagliptin and the alogliptin. And you can this is a busy slide, you can just go through that. And let us come to the pharmacokinetics and pharmacodynamics of vildagliptin versus sitagliptin. So the parameters, the vildagliptin oral 100 mg per day, that is 50 mg BID or 100 mg SR OD, whereas sitagliptin oral 100 mg, or you can go for 50 mg or you can go for 25 also. It's available in 3 strengths. And the dosage change in the renal dysfunction, no, that's what I said. As far as 45 ml per minute, you don't need to reduce that. Pardon?
The screen is not seen, sir.
Screen is not visible.
Yes, sir. Yes, sir.
Yeah, thank you. Yes. So when compared to that, see, vildagliptin in hepatic dysfunction, it's not recommended actually, whereas the sitagliptin, no clinical experience in severe hepatic impairment. See, you can use sitagliptin until the NAFLD and the NASH. Once fibrosis sets in, you cannot use these 2 molecules actually. So the teneligliptin can be used, but I mind you, please don't use this teneligliptin which has got no CVOTs at all. And now the off patented, you can go for the cheaper versions are available, the Indian generic versions like vildagliptin is available and the sitagliptin, both have become off patented. Instead of writing teneligliptin, I request my professional colleagues, please switch over to either of these molecules, whichever you are fond of, you can go for that. And these are the thing is it doesn't have the COOT. It doesn't mean that it doesn't have, vildagliptin doesn't have cardiovascular safety. It has cardiovascular safety, but only thing is it has the other DPP4 inhibitors, they all have this, like, okay, the sitagliptin has got the COVT, Tecos, whereas the saxagliptin has got sevartimi, and as well as the linagliptin has got the both carmelina and the carolina. So this doesn't have the COVT, but okay, the meta-analysis of the clinical studies revealed no increased risk of heart failure with vildagliptin, and efficacy, no significant difference in efficacy and safety between vildagliptin and sitagliptin, because A1C reduction is more or less 0.6 to 0.7%. And sitagliptin in the treatment of type 2 diabetes, it's a meta-analysis. So meta-analysis of 18 clinical studies, and the significant reduction in A1C by 0.74%. So significantly improves the homeostasis model assessment of the beta cell, that is HOMA beta index versus placebo. And one thing I can tell you, the more or less the reductions in the A1C are more or less same, but the maximum A1C reductions are seen with sitagliptin 100 milligram only, not with the lower doses. So the hypoglycemia versus adverse experiences and the serious adverse experiences were less common. And this is effect of race on the glycemic response to sitagliptin. We have already talked about it, because the sitagliptin is very much effective, because the DPP4 inhibition that is done by sitagliptin is maximum seen with the Asian population when compared to the Caucasians, and evaluating the cardiovascular outcome trials with sitagliptin, that is the cardiovascular outcome trial TECOS, and the greatest initial HbA1c reductions with sitagliptin in the TECOS population was in Oriental Asians. That's what, when compared to Caucasians, always the Asians have got a lower A1C, the higher A1C reductions, because of better DPP4 inhibition as well as the better SGLT2 inhibition. I mind you, GLP-1 receptor agonist that doesn't have any racial discrimination, no ethnicity, nothing. And now coming to the effect of sitagliptin and the dapagliflozin added to metformin and weight loss among overweight and the obese patients with type 2 diabetes, a systematic review and meta-analysis. It's a meta-analysis of 18 RCTs with 2009 patients of type 2 DM, and the results were the weight loss of sitagliptin treated and the sitagliptin plus metformin treated groups. So this is the alone sitagliptin, the p-value is significant, whereas with metformin it is very significant. And the conclusion is sitagliptin administration with or without metformin might reduce the body weight and the body mass index if these drugs are taken for more than 6 months. Now let us come to the cardiovascular effect of sitagliptin. Sitagliptin has got multiple modes of action, like it works as an anti-inflammatory agent, it works as like antioxidative, it reduces the oxidative stress, and it improves the nitric oxide bioavailability, it decreases the lipid accumulation, and it improves the anti-apoptosis, and it accelerates the regeneration. And effect of sitagliptin and the cardiovascular outcome trials in type 2 diabetes. It's a randomized double-blind study, included 14,671 patients of T2DM in cardiovascular disease. This is about TECA study. So added to sitagliptin, the placebo to the existing therapy. The follow-up period was exactly 3 years. You can very clearly see the placebo is given in this bar, the graphic representation. The blue is the placebo and the red is the sitagliptin. You don't find any difference with regards to this particular the primary cardiovascular outcomes. So primary cardiovascular outcome in this particular TECOS is composite of cardiovascular death, non-fatal MI, non-fatal stroke, and hospitalization for unstable angina. And sitagliptin was non-inferior to placebo. The inference is that the graphs are going very parallel. You can see that the sitagliptin is just following the placebo. So sitagliptin was non-inferior to placebo for the primary composite cardiovascular outcomes with a very significant p-value of 0.001. And the same thing, hospitalization from heart failure also. The rates of hospitalization for heart failure did not differ between these two groups actually, the placebo and the sitagliptin. See, these are all the inputs of TECO study actually. And the adverse events also, the cardiovascular adverse events you can see on the top, the hospitalization for heart failure or the cardiovascular death, you can see they compare with the sitagliptin and the placebo, and the non-cardiovascular outcomes like the acute pancreatitis and the charter defined cancer and the pancreatic cancer and severe hypoglycemia are very reasonably very less and very low when compared to the along with placebo. It is not different from the placebo. So the inference is no significant between group differences in rates of acute pancreatitis and pancreatic cancer and severe hypoglycemia. And now the latest the research says that almost the patient had earlier pancreatitis. The DPP4 inhibitors never induce pancreatitis. And the cardiovascular risk of sitagliptin in treating patients with type 2 diabetes mellitus. This is a meta-analysis of 32 clinical trials composed of 16,082 type 2 DM patients. No significant difference between the sitagliptin group and the control group as far as MACE is concerned, the myocardial infarction, stroke and the mortality. These results demonstrated that sitagliptin did not increase the risk of cardiovascular events in patients with type 2 diabetes mellitus. And the 2019 ESC heart failure guidelines, the recommendations for DPP4 inhibitors, the 2019 new recommendations. See, this is the level of recommendation 1A, 1B, 2A, 2B, 3A, 3B, 4A, 4B. So the one that is given is light green is the 1A, that is the most the safe and the highest level of recommendation. And 2A is okay, and 2B and from 3 onwards we are not supposed to. So when coming to the treatment to reduce heart failure risk in type 2 diabetes mellitus, the green is the SGLT2 inhibitors. Only the empagliflozin, canagliflozin and dapagliflozin are recommended to lower the risk of the heart failure for hospitalization. If the EGFR is more than 30 ml, I have told you already. And metformin should be considered in patients with diabetes, and HF if EGFR is more than that. The same guidelines they hold good for metformin also. The revised guidelines, earlier it was 45 ml per minute. Now it is, if the patient is already using, you can go until 30. If you want to initiate a new the patient, you want to keep the patient on metformin for a new patient, the cutoff is only EGFR of 45 ml or above. So insulin treatment, the heart failure may be considered, and GLP-1 receptor agonists and DPP4 inhibitors, sitagliptin and linagliptin, have a neutral effect on risk of heart failure and may be considered. And as I told you, DPP4 inhibitor, the saxagliptin should never be used in heart failure, and keep an eye over even allogliptin also, because allogliptin also has got the cases recorded where it is associated with the increased risk of heart failure. And as you are all aware, like thiazolidine, the only DAN available is the pioglitazone in India, but rosiglitazone is very much available. Pio is very much available in the United States with a black box warning, but okay, it should not be used in heart failure. It should not be combined with insulin. So you can see this, the cardiovascular and the CKD outcomes, this bar diagram, and the kidney function declined at the same rate in both the treatment groups with a marginally lower but constant EGFR difference, that is minus 1.3 ml per minute per 1.37 meters of body surface area in those participants who were assigned to sitagliptin. So you can see the different the bar diagrams. One on the left hand side is sitagliptin, and the right hand side is the control. And the blue bar diagrams is the albumin creatinine ratio, that is the red graph, that is that shows the EGFR, and you can see very clearly the sitagliptin group and the control group. They say the sitagliptin group mean urinary albumin excretion measured as urinary albumin to creatinine ratio was markedly decreased, but no changes in the estimated glomerular filtration rate were seen throughout the study. So it is kidney neutral, it is heart neutral, it is weight neutral. And the 10-year follow-up of sitagliptin treatment in patients with type 2 diabetes mellitus with HOMA beta and HOMA IR in sitagliptin group and the control group to estimate the insulin resistance actually. So you can very clearly see that the beta cell function as evaluated by the homeostatic model assessment of beta cell function values was reduced at baseline in both the groups, improved significantly in the sitagliptin group, and continued unchanged in the control group during the study. And the dapagliflozin is effective as an add-on therapy to sitagliptin with or without metformin in a 24-week multi-center randomized double-blind placebo-controlled study. So 432 type 2 diabetes patients were randomized to receive dapagliflozin 10 mg or placebo added to sitagliptin 1100 milligram a day plus or minus metformin, that is more than around 1500 milligram per day. So you can see on the left hand side the typical curves, the line with the rounded circles is the sitagliptin plus placebo, whereas the bottom line with the squares is the dapagliflozin plus sitagliptin. You can see the separation of the curves from the beginning. At week 24, dapagliflozin significantly reduced the mean HbA1c levels by 0.5% versus placebo, and so this is again dapagliflozin reduced body weight versus the placebo. The comparison is 2.1 kilos and 0.3 respectively, and reduced HbA1c levels in patients with baseline values of around or more than 8%. So in my clinical practice, I have seen the weight reductions with dapagliflozin are the maximum. I have seen until 10 kilos of weight reduction with diet and exercise and the lifestyle modification and the therapeutic lifestyle the changes. Not alone dapagliflozin or empagliflozin can reduce the weight, but the patient is very much motivated and he listens to our counseling, the diet exercise along with these drugs will definitely, and the metformin, the maximal dose, and the dapagliflozin minimum reduction is 4 to 5 kilos for any given patient. So followed by empagliflozin, and I don't have any experience with canagliflozin, sorry. And the efficacy of dapagliflozin plus sitagliptin. So you can see the fixed dose combinations, FDCs of EMPA plus LINA versus LINA, and DAPA plus SAXA versus SAXA, DAPA plus SITA versus placebo, DAPA plus VILDA versus VILDA. So the A1C reduction for EMPA plus LINA versus is 1.1 versus the reductions are 0.7, and weight reduction is 2.6 versus 0.7, and coming to DAPA plus SAXA versus SAXA is 1.2% A1C reduction versus 0.9, whereas weight reduction 2.1 versus 0 kilos, and DAPA plus SITA is 0.8 versus 0 as far as A1C is concerned, and the weight reduction is 2.1, and DAPA VILDA versus VILDA is no clinical data available in with regards to the reductions in the A1C and the reduction in the weight. So significant reduction in the A1C and the body weight with SGLT2 inhibitors plus DPP4 inhibitors combination therapy compared to monotherapy with the gliptins. Actually, so this particular the juncture, I would like to give you a practical clinical pearl. See, with regards to the weight reduction, See, the combination doesn't make any change. The combination of SGLT2 and DPP4 inhibitors is not going to do any miracle or magic. See, the magic is done by only SGLT2 inhibitor, either the empagliflozin or the dapagliflozin. Not the all the DPP4 inhibitors are the side actors. They are weight neutral only. Only thing is they don't increase the weight, at the same time they don't decrease the weight also. So this is out of my clinical experience I am telling you. And the guidance for initiation of SGLT2 plus DPP4 FDC based on the glycemic control and appropriate use of this particular combination FDC based on the glycemic control. Like coming to the management of diabetes, like we always divide uncontrolled on metformin plus second line, and on the other hand insulin plus other agents. And the uncontrolled on metformin and the second line, uncontrolled on metformin plus DPP4 or SGLT2 inhibitors, and use in place of DPP4 or SGLT2 when HbA1c is more than 7.5, and uncontrolled on metformin plus the second line of agent except DPP4 and SGLT2. Add this FDC when HbA1c is above the 8.5 on other glucose lowering medications, and replace when HbA1c is above 7.5%. This should be individualized for each patient. And coming to the insulin, the combination may be used as an add-on to insulin with an individualized approach, and the ensuring appropriate titration of the insulin. So I would like to stress upon this particular point. Any A1C of around or above 9 is an indication for initiation of insulin. It is irrespective whether the patient is on single drug, 2 drugs, 3 drugs or 4 drugs. This is according to the American Diabetes Association guidelines. You have to switch over to some kind of insulin. Let it be basal insulin or basal plus insulin or basal bolus insulin or biphasic premixed insulin. Whatever, any insulin has to be initiated if the A1C touches 9. And likewise, this particular the advantage of, if you want to give the advantage of SGLT2 inhibitors to your patients, initiate SGLT2 inhibitors in the very early course of disease process, because if you try to add this SGLT2 in a later phase, you may not be able to initiate, maybe because of the low EGFR, which is a contraindication, and the same thing to have the benefits this particular the 3-point MACE, as well as the heart failure and the hospitalization for heart failure. And if you want to have all this, the protection against the kidneys, protection against heart, the reduced levels of the hyperuricemia, the uric acid levels, you have to start this SGLT2 inhibitor in a very, very early stage of the patient's course actually. So the combination is well accepted, and nowadays some companies are planning to come with the SGLT2 plus DPP4 plus. Already I think the Merck people and the Sun people have introduced the sitagliptin 10 milligram with dapagliflozin 10 milligram, the sitagliptin 100 milligram and dapagliflozin 10 milligram and 1000 milligram of sustained release metformin at a very affordable price of 19 rupees, 19 rupees, less than 20 rupees. You can give the triple drug protection in the drug naive patient or the newly diagnosed patient. And the guidance for initiation of SGLT2 plus DPP4 FDC based on the cardiovascular risk, including heart failure and the HbA1c criteria. One is the SGLT2 inhibitors, and second is this, and third is this combination of two. And SGLT2 inhibitors with proven cardiovascular and heart failure benefits are preferred agents in cases with cardiovascular disease, including heart failure. And as far as DPP4 inhibitors is concerned, they are proven with CV and heart failure safety, such as linagliptin and sitagliptin have shown a favorable CV safety profile, including no increased risk of hospitalization due to heart failure in the COVTs. But as far as this particular CKD is concerned, you need to down titrate the dose of all the gliptins except linagliptin. And finally, the inference is the combination may be preferred over other conventional therapies, those with no CV benefit in case of the established CV disease and or the heart failure risk. And the guidance for initiation of the same combination, the SGLT2 and DPP4 FDC based on promoting weight loss or the preventing hypoglycemia, and based on the promoting weight loss and preventing hypoglycemia, again the A1C criteria applicable as above the SGLT2 inhibitors. The SGLT2 they promote weight loss, the DPP4 inhibitors I said nothing to do with weight reduction, they are just weight neutral, and this combination may be preferred over the other conventional therapies to promote weight loss with no increased risk of hypoglycemia in type 2 diabetes management. See, that's what we have seen in the Carolina. That was the only one study, that one cardiovascular outcome trial done with the linagliptin. Actually, the Boehringer people did that. The two CVOTs, that particular molecule has got the linagliptin is, one is Carbolina and the Carolina. The difference is Carbolina has got the high CV risk patients, whereas the Carolina has got low CV risk patients, and the active comparator was all the time versus placebo, but Carolina was the only one study of its kind where the active comparator was glimepiride actually. So, and finally the results of Carolina also said the glimepiride is good, but it increased weight to a tune of 5 kilos after the end of the study, the 5 years, and there was significant increase in the L3 hypoglycemias in the glimepiride arm when compared to the linagliptin arm. So they don't produce hypoglycemia per se, DPP4 inhibitors. They don't produce this particular they are weight neutral, and the cardiovascular neutrality is there for the sitagliptin and the linagliptin. And the take home message is SGLT2 inhibitors and DPP4 inhibitors, they have a complementary mechanism of action. This combination may be a pertinent partner to metformin in providing meaningful glycemia control without increasing the risk of hypoglycemia, and in improving the metabolic profile of the patients. And dapagliflozin and sitagliptin FDC has potential for improving adherence along with the glycemic control and CV benefits. So to end my the speaker program, so my take home message is, if you want to start this SGLT2 inhibitor this thing, start very early in the course. Don't wait for the funda is hit early, hit hard, that's all. And second thing is, where it is contraindicated, please don't try it in type 1, because European Union, it is the European Medical Agency EMA and the European Commission has given the approval for empagliflozin and dapagliflozin and sotagliflozin. There is one more gliflozin, that is sotagliflozin. The dual blockade is there, that is that inhibits SGLT1 as well as SGLT2 inhibition. So they are using in the European Union along with insulin these three the SGLT2 inhibitors, but as of now there is no recommendation from any international body that these drugs can be used along with insulin in type 1. So please never ever try these drugs but for the type 2 diabetes mellitus, and know where it is to be used and know where it should not be used. So with that I conclude. Thank you so much for your kind patronage and kind listening, and if there are any questions we'll take up.